Hello everyone. I am Dr. Abdikhani Ahmed Abdi, and today we're going to talk about Acute Respiratory Distress Syndrome, ARDS. ARDS is one of the most critical conditions we manage in the ICU, and early recognition can make a major difference in patient outcomes. In this session, I'll guide you through the key points: what ARDS is, how it develops, how we diagnose it, and most importantly, how we can support and treat these patients safely and effectively. Let's start from the basics and build our understanding step by step. Before we begin, here's a quick overview of what we'll cover today. First, we'll look at a brief introduction to ARDS, what it is and why it matters. Then, we'll move on to the clinical manifestations, focusing on early and late signs that we should never miss. Next, we'll discuss the diagnosis, especially the Berlin criteria, and how we apply it in real ICU practice. And finally, we'll wrap up with a conclusion summarizing the key points for daily critical care work. ARDS is a sudden and severe inflammation of the lungs. Because of the inflammation, the alveoli become more leaky, fluid enters the lungs become stiff, and the patient becomes severely hypoxic, even with oxygen. So ARDS is basically inflamed, leaky, stiff lungs with severe hypoxemia. Now let's look at the epidemiology of ARDS. ARDS is not rare in the ICU. About 10 to 15% of all ICU admissions meet the criteria for ARDS. The condition is serious. The mortality rate ranges from 26% up to 58%, depending on severity and comorbidities. Most patients with ARDS don't die from the lungs alone. The major cause of death is multi-organ dysfunction, often triggered by sepsis. In the general population, the incidence is about 13 to 23 cases per 100,000 people per year. We also see that ARDS is more common among mechanically ventilated patients, especially those with acute lung injury, which occurs in about 16% of ventilated patients. So overall, ARDS is both common and severe, which is why ICU teams must recognize it early. Next, let's talk about the common causes of ARDS. The most common cause is sepsis. Severe systemic infection triggers a strong inflammatory response, and that inflammation damages the alveolar capillary membrane. Other important causes include aspiration of gastric contents pneumonia, both bacterial and viral, multiple blood transfusions, severe trauma, acute pancreatitis, and near drowning, where large amounts of fluid enter the lungs. What all these conditions have in common is that they trigger widespread inflammation, which then leads to lung injury and ARDS. So whenever we see patients with these risk factors in the ICU, we must monitor their oxygenation closely. Let's go through the pathophysiology of ARDS step by step. It all begins with a lung injury, which triggers a strong inflammatory response. That inflammation makes the capillaries leaky, so fluid enters the alveoli, filling the air spaces where gas exchange should occur. Because of the inflammation, the amount of surfactant decreases, and the alveoli start to collapse. When many alveoli collapse, the lungs become stiff, so lung compliance drops. As a result, the patient develops severe hypoxemia, and if not treated promptly, this progresses to respiratory failure. So the entire process is a chain reaction: inflammation, fluid in alveoli, collapse, stiff lungs, hypoxemia. Here are the early clinical signs we often see in patients developing ARDS. One of the first things you'll notice is restlessness. When oxygen levels start to drop, patients become uncomfortable and unable to relax. Next is dyspnea. They start breathing faster or say they feel short of breath, even before the numbers change. You may also see low blood pressure, especially in patients with sepsis, which is a common cause of ARDS. Neurological changes are also important early clues. Patients may develop confusion, become unusually sleepy, or just not act like themselves. Some show extreme tiredness, and others have changes in behavior or consciousness, such as mood swings or disorientation. These symptoms may look subtle at first, so nurses at the bedside are key in catching them early. When ARDS gets worse, the patient will show late or severe symptoms. These include very hard and fast breathing, severe shortness of breath, fast heart rate, thick, frothy sputum, metabolic acidosis, cyanosis, blue lips or nails, crackles or abnormal breath sounds, low PaO2, and low PeEP-FiO₂. These signs mean the patient is in serious respiratory failure. To diagnose ARDS, we look at three main things. Timing. Symptoms start within 1 week of a known cause chest X-ray. Both lungs show opacities, the white outlook oxygen level, ABG mild PaO2/FiO2 200 to 300 moderate, 100 to 200 severe. Less than 100 we may also use CT scan or echocardiography to rule out heart failure. This is what ARDS looks like on a chest X-ray. You can see bilateral ground glass opacities. Both lungs look hazy or white, not clear. This appearance shows fluid and inflammation in the lungs. ARDS is divided into 3 levels based on oxygenation. Mild PaO2/FiO2 200 to 300 moderate, 100 to 200 severe. Less than 100 all patients need PEEP greater than or equal to 5 cm H2O. The more severe the ARDS, the higher the mortality risk. Now let's look at the key nursing priorities when caring for a patient with ARDS. First, continuous oxygenation monitoring is essential. We watch SpO2 trends and use ABGS to confirm how well the patient is oxygenating. Next, we must maintain a clear airway. These patients often have thick secretions, so regular suctioning is important to keep the airway open. Positioning is another major intervention. Keep the head of bed elevated 30 to 45 degrees to improve ventilation and reduce aspiration risk. For moderate to severe ARDS, we should also consider prone positioning if appropriate. Strict I/O monitoring is crucial. We avoid fluid overload because excess fluid worsens oxygenation. We also monitor the patient's hemodynamics closely. Blood pressure, heart rate, urine output, all of these help us evaluate perfusion status. To prevent ventilator-associated pneumonia, we focus on oral care, sterile suctioning, and proper ventilator care. And finally, we should not forget psychological support. ARDS patients, especially those on ventilators, often feel anxious and scared, so communication and reassurance make a big difference. Now let's talk about the ventilator strategy for ARDS. Everything we do here focuses on lung protective ventilation to prevent further lung injury. The first key point is low tidal volume ventilation, usually 6 milliliters per kilogram of ideal body weight. This prevents overstretching the alveoli, which is a major cause of ventilator-induced lung injury. Next is PEEP, which helps keep the alveoli open and prevents collapse, especially in the dependent parts of the lung. We also try to avoid high FiO2 for long periods. High oxygen can cause toxicity, so we use the lowest FiO2 that still maintains adequate oxygenation. Prone positioning is another important strategy, especially for moderate to severe ARDS. It improves oxygenation by recruiting more alveoli and improving ventilation, perfusion matching. Finally, sedation or neuromuscular blockade may be used to reduce oxygen consumption, improve synchrony with the ventilator, and prevent patient ventilator fighting. Overall, the goal is to protect the lungs while supporting oxygenation as safely as possible. Here is the simple idea of ventilator management in ARDS. We use lung protective ventilation to avoid hurting the lungs even more. Low tidal volume, about 6 milliliters per kilogram IBW. To avoid overstretching the alveoli, PEEP. To keep alveoli open and prevent collapse, use the lowest FiO2 possible. To avoid oxygen toxicity, prone position. Helps improve oxygenation in moderate to severe ARDS. Sedation or paralysis. Helps the patient stay in sync with the ventilator and reduces oxygen demand. Our goal is simple. Protect the lungs while keeping oxygenation stable. Here are the main complications we need to watch for in ARDS. Barotrauma, like pneumothorax, because the lungs are stiff and fragile. Oxygen toxicity, from using high FiO2 too long. VAP, ventilator-associated pneumonia. Multi-organ failure, common in sepsis-related ARDS. Pressure ulcers, especially in patients placed in prone position, so we monitor the lungs, oxygen levels, skin, and organ function very closely. For ARDS patients, supportive care is very important. Start early enteral feeding. It helps maintain gut function and improves recovery. Keep fluid balance. Avoid giving too much fluid. Control temperature and blood sugar. Provide good skin care. Give emotional and family support. Because these patients and families are often very stressed, these supportive measures help stabilize the patient and improve overall outcomes. To conclude, here are the key points. Recognize ARDS. Early oxygenation and ventilation are the top priorities. Use lung protective ventilation monitor ABGS, urine output, and hemodynamics. Prevent complications like VAP, pressure ulcers, and barotrauma, and always support the patient and family emotionally. These basic principles guide safe and effective ARDS care. Thank you everyone for your attention. That's the end of today's session on ARDS. If you have any questions, feel free to ask. I'm happy to discuss any part of the topic with you.